Good evening, Deepti ma'am. Can we start the meeting?
Uh, Sir, Pragnesh Parmar, sir, can we start, sir?
Yes, we can start. We have all the panelists, esteemed speaker with us. Moderator is there. So, and 60 participants are there total, all of us. So, I think we can
Ah,
start.
okay, Dr. Vijay.
Yes, ma'am. Good evening, all. Tell me and forget. Tell me and I forget. Teach me and I may remember. Involve me and I learn. So, with this quote from Benjamin Franklin, I, Dr. M. Vijay Karthikeyan, the National Treasurer of IAME, feel privileged and delighted to welcome you all for this panel discussion organized by the South Zone of IAME and which features four esteemed panelists who are very well known in the field of medical education. Now we request our national president, Professor Dr. Pragnesh Parmar sir, who is also the professor and head of the Department of Forensic Medicine and Toxicology, AIMS Bibinagar, to deliver his welcome address. Over to you, sir.
Thank you, Dr. Vijay. So, on behalf of IAME, it's my immense pleasure to welcome you all on this today's panel discussion. I first welcome all the panelists, respected Dr. John sir, who is from Karnataka, respected Dr. Sunita madam, who is from also from Karnataka, respected Dr. Sudha madam from Tamil Nadu, and respected Dr. Zayaparasarasan sir from the JIPMER, Pondicherry. So, and the today's topic is very interesting. We all dealing with the CBME, Competency-Based Medical Education, and now today we discuss on assessment, bridging gaps and building solutions. So usually we have seen many webinars in which there is a only oral lectures or some PowerPoint presentation, but here we have panel discussion followed by question answer sessions. So I am sure we all of us will learn today something new in the field of assessment. So I welcome all the speakers, all the member of IAME, as well as all the participants who joined today to learn something new. So I am very happy and I am sure we all of will learn today. So we can proceed further. Thank you.
Thank you, sir. Thank you for your inspiring words, sir. Next, I would like to invite Professor Dr. Rajavel Murugan, sir, who is the South Zone Secretary of IAME and is also the Professor of General Medicine from Government Thoothukudi Medical College, to deliver the address on the theme for today's panel discussion. Over to you, sir.
Good evening, Dr. Vijay. Am I audible?
Yes, sir, you're audible, sir.
Good evening, all, and greetings from South Zone IAME. So, nowadays, the four letters, that is the CBME, is driving every medical teacher in India crazy, chaotic, and confused. We all know that one side of the medical education, we are just teaching in the assessment of CBME, multi-source feedback, mini cakes, DOPS, portfolio, everything. But in other side of medical education, in summative evaluation, we are just assessing each and every student in every institution with just a long case, a short case, and ASCII for 2 or 3 stations. That is only happening in all the institutions. In one side of the medical education, so we are teaching that multi-station ASCII, there is a 18 to 20 station ASCII is the best to assess the student. But in another side, in all the institutions, we are just assessing with just 4 or 3 ASCII or ASCII station. So this is what happening in all the institutions. So there exists a huge gap between the expectations and the reality. So that is what happening. So let us all hope that this webinar will address the gap and also the solutions in a CBME assessment. So the four-letter word CBME may be bitter for the young teachers who do not know much about the medical concept. So let us all hope that this webinar will convert the bitter CBME four-letter word into a sweet four-letter word like just LOV. So I welcome all the eminent panelists and the moderator to this webinar. So let us all listen keenly, right? So over to moderator.
So thank you, sir. Thank you for your inspiring words, sir. And also thank you for suggesting this topic for the panel discussion, sir. So next, I would like to invite Professor Dr. Sangeeta ma'am, who is the Professor and Head Department of Biochemistry and is also the EC member of IAME from Government Medical College, Viluppuram, to introduce our esteemed moderator for the panel discussion, Professor Dr. Deepti Shastri, ma'am. Over to you, ma'am.
Thank you, Dr. Vijay. It's my privilege and honor to introduce Professor Dr. Deepti Shastri, ma'am, a distinguished educator with her vast knowledge, dedication, passion for excellence. She has made a significant impact in medical education. Ma'am is a Deputy Dean at Vinayaga Mission Kripananda Warrior Medical College and Hospital, Salem, Tamil Nadu, and Dean of Faculty, Medicine at the same university. And ma'am received a Global Faculty Award 2021 by AKS Education and recognized as an eminent medical teacher by InnovaCare E Academy and MU India. And ma'am is a resource faculty lecture series in anatomy, Swayam Prabha, and ma'am recognized as a president, Academy of Dental Education, member Board of Studies in Preclinical Medicine, Goa University, and Kerala University of Health Sciences. And ma'am is a editor-in-chief, National Journal of Medical Sciences 2016 to 2019. And ma'am published nearly 50 national international journals, and she organized 20 conferences, workshops, and CME at institution, regional, and national level. Now, I would like to invite Deepti Shastri ma'am to moderate the sessions. Over to you, ma'am.
Thank you, Dr. Sangeeta.
Good evening, Deepti Shastri, ma'am. I would like Deepti Shastri, ma'am, to introduce the panelists for today's session. Over to you,
ma'am. Thank you, Dr. Vijay.
Yes.
Well, quoting from Dr. V.K. Paul from his foreword in the assessment module of Undergraduate Medical Education 2019, if it is not assessed, it is not learned. As the first cohort of the CBME curriculum, the 2019 MBBS batch is nearing completion of internship. It is an opportune moment for us to analyze the assessment modalities within the CBME, identify the deficiencies in the assessment methods, explore the challenges in its implementation, and assess the impact on student performance. To facilitate this discussion, we have a panel of medical educators who have served as or are the conveners of the regional and nodal centers of medical education technologies from various esteemed institutions. Please join me in welcoming them to today's panel discussion on CBME assessment, bridging gaps, and building solutions. Let me first begin with Dr. John Stephen. He is the professor and head Department of Dermatology at Sri Chandrama Dayanand Sagar Institute of Medical Education and Research and is the Director of Medical Education at the same institution. He has 20 years of teaching experience and 15 years of medical education leadership. He was formerly the convener of NMC Nodal Center for Faculty Development, member NMC's expert group monitoring implementation of competency-based medical education, and is a member of experts group UG Medical Education Board NMC. We next have Dr. Sunita Y. Patil. She is a professor of pathology at Jawaharlal Nehru Medical College, a nodal officer at the Academic and Administrative Development Centers, Director, University, Department of Education for Health Professionals, KLE Academy of Higher Education and Research, Belagavi, Karnataka. Her professional contributions are: she is a former member, Reconciliation Board of the erstwhile Medical Council of India, now the National Medical Commission, co-member in curricular reforms, especially in designing the CBME undergraduate medical curriculum implemented in 2019. She is a contributor to the competency book published by the erstwhile Medical Council of India for the implementation of the new CBME curriculum. She has been invited by National Commission for Indian System of Medicine as an expert to develop a structure and plan for the implementation of faculty development programs across the country for Ayurveda, Siddha, Unani, and Soa Rigpa faculty across the country. We next have Dr. Sudha Ramalingam. She is the Director, Research and Innovation, and Director, PhD, FAMER Research Regional Institute, Professor and Head, Community Medicine at PSG Institute of Medical Sciences and Research, Coimbatore, and works at the Harvard T.H. Chan School of Public Health, USA. Her awards and achievements are: she bagged the University Gold Medal in MD Community Medicine and has been awarded as a Best Teacher and Best Motivator. She has a postdoctoral fellowship from Stanford University, University of Chicago, and is a Fulbright Scholar from Harvard T.H. Chan School of Public Health. She is a visiting scientist, Global Health, Harvard T.H. Chan School of Public Health, and has an international fellowship in medical education, FAMER, USA. Last but not the least, we have Dr. Z. Zayaparasarasan. His name is as difficult as his achievements. He serves as the Professor and Head, Department of Medical Education, and is the convener of the NMC Nodal Center for Medical Education Technology at JIPMER, Puducherry. He holds a PhD in Education Technology, that's medical education, and is a FAMER Fellow. He is certified as an American College of Surgeons ATLS educator. He has co-authored 2 books, edited the first volume of Best Educational Practices in Medical Education, and has contributed to 5 book chapters on education. He has authored over 30 papers and received recognition as an Air India Broad Outlook Learner Teacher Awardee. He has been a visiting scholar at the University of British Columbia, Vancouver, Canada. He has led departmental research projects, conducted workshops, and presented papers at international and national conferences. Currently, he is supervising 3 PhD scholars in health profession education. So we are privileged to have heavyweights in medical education on our panel today. Let's begin with the deliberations with our esteemed panelists now. I would like to first specify the goal of our panel discussion. It is to gather different perspectives on CBME assessment from our esteemed panelists. So what we'll do is we'll have 2 rounds of questions which are addressed to each panelist in turn by the moderator. And this would be followed by a few questions that any panelist can choose if they wish to. This would be followed by questions by the audience and closing remarks by the panelists. This would be followed by a brief summary of the deliberations. So shall we begin with the question answer sessions? So round 1 questions. Dr. John Stephen, sir, has been the head of Department of Medical Education. So, sir, you have had a first-hand experience of transition from traditional curriculum to CBME curriculum. So, can you briefly explain the fundamental principles of competency-based medical education and how it differs from traditional curriculum?
Thank you. Let me first thank the organizers for inviting me here. And it's a great pleasure to be a part of this panel. And I guess you can hear me, right?
Yes, sir.
Yeah, okay. No, CBME, I've been thinking about it. And I think the one word that sort of is the key, I think, is that in CBME, the focus is on outcome. Everything follows and is sort of designed for that particular focus on outcome. In the old curriculum, it was more to cover the curriculum, cover the topic, and go through the process. So here we are looking at outcome. The focus is on the outcome. And therefore, because the focus is on outcome, there's a certifiable skill. Because the focus is on outcome, you need just a one-off summative exam will not solve the problem. So you need formative assessment as the key to competency-based medical education. You need integration with clinical practice, and you need flexibility in the training as well. It's not, compartmentalized into lectures and tutorials. It goes beyond that. So I think the main focus, I would say, is to do with CBME is basically the focus on outcome. And therefore, this particular topic on assessment, in a way, that's the challenge. And how do we ensure that what we want as the outcome is actually achieved? And I think in very brief terms, I would say CBME is the two things that I want to sort of flag here, many things that we can talk about, is that CBME is outcome focused. Okay, it's not based on a syllabus and a defined sort of, there's a curriculum, yes, but it's not focused on what needs to be done, but it's on outcome that we focus. And I think the key to achieving that outcome is the formative assessment. I guess we will come around and round to that. In so many ways, it will be about assessment. So that would be my brief answer to your question. If there's any elaboration that you want, we could go.
Yes, sir, you're perfectly on point. Earlier, we faculty were behaviorists, where we controlled the situation in a classroom. And now it is more towards constructivism, where we focus on the learner's achievements rather than focusing on what the teachers want to teach. That is the reason formative assessments are much more important, where there is assessment for learning rather than summative assessment. Thank you for your insights, sir. Now I'd like to direct my next question to Dr. Sunita Patil, who has educated all the medical educators. I would like to say that because of a lucid scientific article publication on blueprinting for question paper. I'm sure that is the gold standard for any university that is setting up a blueprint of question paper. So, ma'am, the next question is directed towards you. What should be prioritized when assessing medical students? Is it skills or competencies? And what methods can be utilized to measure them effectively?
Thank you very much, madam. At the outset, again, I would like to thank all of you and the organizers for having given me this opportunity and considering me to be here. Yeah, this is a very good question, ma'am, because many a times we come across this. What should we do? Skill or competency? But here, we cannot say whether it is a skill or competency. We need to understand what is a skill and competency. In spite of training, many of the faculty get confused. Both are, same. Because most of the CBME is based on, skill-based. Everybody thinks the focus is on skills and the formative assessment of these skills. One example I can tell you, to share here is, the skill is when we are doing any particular task. Suppose I can give an example of IV, putting an IV line. I can say maybe we are doing it in with the checklist and everything, we are doing it in a skill lab. Then that becomes a skill. Here, the student is doing mechanically without any context. When any student performs any skill without a context, we just call it as a skill. He's proficient, he or she is proficient in performing putting the IV line correctly as per the checklist. But what is it that takes for a skill to become a competency? Is the contextual concern here. When in a context, in a clinical context, if the student knows when to put IV line, what are the indications, how can I put, and what are its implications, with in the background of having those emotions, the knowledge, not only knowledge and skills, having those emotions, the decision making, the reflections and entire thing when he is doing it on a patient with as a human with a holistic approach, that becomes a competency. So we need to understand the attainment of competency is incremental. Naturally, the student is not going to directly put an IV line on a patient in a hospital setup, in a clinical setup. So that patient, he or she has to be trained before in the skill lab. So when we are assessing for the skill, it should be in the skill lab. So skill is important there. Skills assessment is, we have to prioritize. But when the student goes to the clinical setup, when we are assessing them in the clinical setup, yes, that time it is the competency. So we have to focus on both these areas. So it's just not there are a set of skills to attain a certain competencies. So we can say that it is on the way, the next step to competency. So that we have to prioritize. Second point is we have to prioritize on the competencies that are the core competencies, of course. Assessment of all the core competencies is very important. And when we are assessing, we have to take that cumulative assessment. What we can say is we are assessing now what is happening is we are assessing competencies separately. We assess the competencies of knowledge separately. We assess the competencies of skills separately because it is coming as the contextually there. And we are assessing certain competencies in the affective domain separately. However, what we need to look at is all these have to be assessed cumulatively or record them cumulatively so that each of these particular domains of competencies have been assessed. So that is if it is. Otherwise, if I have a little more time, I would like to quote a story, a narrative, a comparison that was given by in an article by Dr. Nilima Shah, Piyush Gupta, and Tejinder Singh sir, which was published last year. A skill or competency, what should we be assessing? They give a beautiful narration, which is in comparison to Mahabharata story. In Mahabharata, I mean, I'm quoting that. I can share that article. Of course, everybody knows that it was published last February 2024. How we can compare to understand is that there is Ekalavya who learned how to, use a bow and arrow. He was competent enough without any teacher. He was competent enough. That is what he learned, Shastra, to use Shastra. But he could not use Brahmastra or he could not command an army because he did not learn Shastra. So Shastra and Shastra are different. He learned Shastra, but he did not learn Shastra. On the other hand, we have Duryodhana, who learned Shastra and Shastra both in a very authentic way from proper teachers, but he lacked ethics and professionalism. Next, we have Arjuna, who learned Shastra, Shastra, who also had all ethics and professionalism together. He was competent that way of what we are looking at the competencies. He had ethics, he has professionalism, he has skills, he has competency, he has everything. But when the situation came, because the context at the time of war, he was very competent, but at the time of war, he backed out, or rather you can say he was hesitant. That was because the context changed, because our own people, my own people are there, the context changed. Here comes the role of Krishna, who acting as a teacher or a mentor on a subjective assessment, his own assessment. He didn't send him for a remedial class or another skill lab session or another session. He decided that he knows it, but he just needs, that he at that moment he helped him navigate through the situation in ethical and professional dilemmas. He helped him navigate through that. So here, if we compare the role of all these characteristics, especially the role of Krishna, is that it's like a perfect teacher and a mentor, what we are looking out for in a CBME. The context differs. So we are not looking at just the competency. We are looking at these competencies should be applied in real life situations throughout their life. This is what we are looking at. So
Thank you so much for that nice interpretation of Mahabharata, ma'am. We can also interpret that Arjuna is an advanced learner, and Karna probably was an average learner who also had his own limitations, and Eklavya was a self-directed learner. So
correct.
CBME in Mahabharata as well. So we have always been, Indians have always been advanced. You know, we always look towards the West, but we have had the best gurus, Guru Shishya Parampara, and so on. Thank you so much for your insight, ma'am. We'll now move on to Dr. Sudha, ma'am. Dr. Sudha, ma'am, you have trained innumerable faculty members in medical education technology at PhD as well as FAMER fellows. So I'm sure all the faculty members who are trained under you must be relating about the limitations they have in implementation of CBME assessments. So my question to you is, what are the common gaps that you have noticed in the implementation of CBME, specifically regarding assessment practices? And what measures should be taken to address these gaps?
First of all, I would like to thank the organizers for giving me this opportunity. I apologize for my throat. Hope you're able to hear me. So in this question, I would like to divide it into three domains or three different sections. One is student related, right? As a teacher and also as a trainer of faculty, what I observe is there's no active participation from the student, though the primary objective of CBME is student-centered. They are passive consumers. So if you ask them what is CBME, they won't know. If you ask them assessment, they don't know what they are being assessed for. So that is a major lacuna because we don't include the students in what we are going to assess. And as it happened, the COVID also came, and CBME also came, and there is a lot of technologies which are also emerging, the AI-based technologies, which kind of takes away the the personal touch in learning, as you previously Dr. Sunita said, and you also mentioned the Guru Shishya Parampara. So that is lacking now because most of these kids, they don't come to class and they think whatever they can do it online and things like that. So the technology is being used by them, which is posing additional challenges for us to implement what we are trying to implement. So this is student related. If you come to the faculty, we all will agree. There is no second thought in that. We are all challenged with time. So many of us multitask. Many of us are in MEU, a primary department and administration and so on and so forth. So there is lack of time even to focus on what has to be implemented. And of course, there is high documentation load, which all of you would agree, which should be submitted to the NMC or other regulatory bodies. And there is a lot of migration of faculty. So in the present generation, what I see is they come, they get trained, they be there for a couple of years, and they try to move on to another institute where the salaries and infrastructure and other facilities are better. So the migration of faculty, again, we have to train the newer faculty from the scratch. So that poses a big challenge in implementation of CBME. And of course, the large student ratio, like, the teacher-student ratio poses a major threat to any assessment forms. That is from the faculty side. And the last but not the least is the system. We are not effectively using the tools like the workplace-based assessments and the various assessment which are aligned with CBME because of maybe lack of standardization, lack of training, lack of infrastructure. There is a discrepancy between the different institutes across the country. So lack of uniformity across the country. And of course, the administrative support and other logistic support, which are required, which are very crucial, which might be lacking in some of the institutes. So regarding the solutions, I don't know, it's a big, change. I feel, as you mentioned earlier, the NMC should kind of do an evaluation. This is an opportunity for us all to come together. So many of us are here from different colleges, public, private, central, state, like so many institutions are represented here. So probably we should come together to look at what has been done in the last few years. The first batch is leaving us soon, probably the next month or next couple of months. So are they really, did they really benefit from the CBME is what we have to look at and, kind of do a course correction if we need to do it. And as faculty and also the institute, we should use effective use of technology. So as such, we are overwhelmed with so much of corrections and assessments. Probably effective use of technologies like a logbook can become an e-portfolio, and use of AI. So for pattern recognition, all these things the faculty needs to be trained. Maybe ACME and the the basic medical course training should incorporate all this to train faculty in lowering their workload. And more public-private partnerships can happen when there is a simulation lab or a skill lab in a particular institute. Another institute can partner and utilize the facilities. So there can be a public-private partnership model which can be thought of. And the alignment with the university regulations and NMC should go hand in hand. Sometimes what the university prescribes will be slightly different from what NMC mandates. So always the faculty are in a little bit of confusion. So this needs to be streamlined. And last but not the least, I'm just thinking out loud. Do we need a student curriculum committee at each institute to listen to their side of the story? They are important stakeholders, but we are not including them anywhere. So these are my thoughts on your question. And yeah, thank you.
Thank you so much, ma'am. You covered all the stakeholders involved in assessment. And I'm very glad that you brought up the question about students' involvement in assessment. Abroad, in allied health sciences in the US, they have what's called as an exam wrapper, where the students are involved in pre-examination, during examination, and after examination surveys, where they have to answer questionnaires based on their readiness to take up the examination. And post-exam, they need to analyze themselves whether they have misinterpreted the questions or misread the questions, or they were under-prepared. The examination questions were above their level, like undergraduate level, it is postgraduate level, and so on. Maybe we need to introduce something like exam wrappers in Indian system as well. And about the students being in the committee, in our institution, in fact, we have students in the student curriculum committee, and we used to find that he would come without being prepared, without discussing with any of the students. So we have framed a student curriculum committee where they meet before the faculty curriculum committee. And he comes up, the student representative comes up with what are the evaluation difficulties or implementation of CBME difficulties that the students are facing. He mentioned about student engagement being improved by giving them project-based learning. And we in fact could do that for them. So I appreciate you for bringing in a student involvement, ma'am. And I would like to thank you. We do know that you have pharyngitis. You are just back from a community medicine conference, and you were a panelist there, and you have difficulty in speaking, but still, just for the sake of all the participants, you have joined in. Thank you so much, ma'am. And thank you for your insights. Next, we move on to Dr. Zayaparasarasan, sir. Sir, as a person who has been training faculty in medical education technology for years, probably since 2009, and because JIPMER is a center for NTTC, even before that, you have been training the faculty. So, sir, the question to you is, what strategies can be utilized to effectively train faculty in developing and implementing meaningful competency-based assessments?
Yes, ma'am. Thank you very much, ma'am. Thank you for at the outset. I thank the organizers for giving me this opportunity, and I would like to congratulate the organizers again for selecting this topic, because which is the need of the hour, where most of the faculty in India are wondering about how to bridge the gap So this gap is not a small gap. It's a large gap because this gap is not created recently. This has been ever since the medical education was started in India. At the time of independence, India had only 12 medical colleges producing around 1,250 doctors. Now India has more than 750 colleges producing nearly 1 lakh doctors a year. So this gap, every year by year, the gap only expands. No, it's not because of the introduction of CBME alone. So already there is a gap, and the CBME has made us to realize that there is a large gap. So one important factor that influences the medical education is that the mindset of the faculty members. So if you look at Indian mindset, I'm not pessimistic about that. So always it's human nature that the mindset, we are already freezed with the old curriculum or with the old mindset, or we can say with the fixed mindset. And it is very difficult to change our faculty mindset to a growth mindset so that they can readily accept the new elements of the CBME or whatever it is. So it's very difficult. It's not only in medical education, whether it is engineering education or humanities or arts or science, whatever it is, it's very difficult to change the mindset of the people. So before thinking about the strategies of for faculty development in view of CBME, first of all, we need to understand where the faculty, what kind of demand we have with respect to the faculty development for the medical teachers in India. So, for example, if you look at the basic thing, when CBME was introduced in 2019, the NMC introduced a common course for all the medical teachers across India that is called as the basic course in medical education. So this course helped the teachers to just gain an understanding about what CBME means. So this also helped the teachers to understand the fundamental aspects or the basic aspects in educational science. So, but this with that it stopped. That's all. So there is no, the organizer, the apex body could not take the course. They cannot take the basic medical education to the next level. Of course, they have an advanced course in medical education, but that has not much to do with the CBME. It is project-based learning where these teachers are expected to identify an important problem, an immediate problem that they are surrounded by, identify a tentative solution, and check whether that particular methodology is working or not. So that is a different thing. But when you talk about the actual faculty development in India, it is a basic course in medical education. It is at the basic level only, as the name says. So it is the responsibility. We think that it is the responsibility of the government or the apex body like NMC to train all the teachers, pull them into the circle, and then make them to sit in a classroom and then train. So it is not like that. There is a saying in English that we can only take the horse to the pond. So it is the responsibility of the horse to drink water. But what happens in our, I'm proud to say that we are not only just taking the people to drink water, but instead of making them to drink, we cannot make all the faculty to drink water. We cannot actively involve all the participants. At the same time, we can create a thirst in them to develop their competencies. And we are all in the 21st century, and we are expected to develop the 21st century skills so that we can handle the 21st century students, and that too, unless we are competent enough, as teachers are competent enough, we cannot develop the competencies in the medical students. To become a competent teacher, we need to develop certain competencies, what I actually call it as the predominant competencies. The first predominant competency with respect to the competency-based medical education is learner-centeredness, which Dr. John Stephen has already mentioned. So it demands a lot of learner-centeredness, as he mentioned about the formative assessment. So formative assessment, we think that some people, we immediately, whenever CBME is said, we said that it is the assessment that drives learning. Of course, it is the assessment that drives learning, but there are also other factors that drives learning, like motivation, learner-centeredness, self-determination, self-regulation, and authentic assessment, so that the learner also feels that I am assessed for some purpose. Before, in traditional curriculum, the students may not know for what purpose they are being assessed. But in competency-based assessment, it demands more authentic environment, authentic assessment, for which our faculty are not prepared. Though we are talking about mini CX, DOPS, and workplace-based assessment, OSCE, and other things, but we don't realize that whether they are really being applied in the authentic environment. So one important area where we need to train our faculty to bridge this gap quickly is that authentic assessment. So before that, we should also check our before talking about the assessment, whether our teachers are really delivering the content as per the competency-based medical education requirements. But still the classrooms are same. We talk about CBME, we talk about assessment, but the classrooms are same. Teachers are going with the same kind of PowerPoint, same type, same content, but there is no proper match with the content and the pedagogy or the technology that they use. So here also we need faculty development. And the next area where we badly need, where we really need the urgent need for faculty development is that the well-beingness of the student as well as the teachers. So now one of the panelists said that teachers are overburdened, students are not responding. One of the important crises in the current crisis in medical education is engaging the current learners. So if we want to make our teachers more empowered, then we will not, if you are an empowered teacher should not complain about students this thing. That means somewhere something is failing. So we need to focus on these things so that the teacher becomes a very active member in the classroom, so that he is able to gain the attention of all the students, he is able to engage the students at different levels so that appropriate competency can be achieved. So that is one area where we can develop. So these are some of the predominant areas so that the elements of so that the elements of competency-based medical education becomes more visible. So if you think that, if you all think that the faculty need to do a constructive or a productive job inside the classroom, we need to train the faculty. Now, what are the strategies that work? So all these days we have been, we believe in the formal way of training the student, faculty, as we have been trained in schools or in the colleges. Still, our faculty want them to call in a particular place, and then they want someone to make them to sit and then take a lecture or give proper. So that is a formal way of training. Of course, that is being very well done by the NMCs, with the direction of the NMCs. But how far it is effective? So so far there is no study to say that this formal training is being effective, because it is linked to the promotion, it is linked to the increment, it is linked to getting a job like that. So as long as it is linked like that, I don't think that there won't be that, because as I initially said, we need to create thirst among the faculty members. So faculty development programs not only just directly provide a formal training for the thing, they should also think of other means of training like informal training and non-formal training. So the informal training, like what we are doing, this is a non-formal training, what we are doing, this webinars, conference, or this panel discussion kind of thing, can serve as a good non-formal training, because here only people who are really passionate towards medical education will participate and contribute. So this kind of platforms will serve better than the formal training, because we are all adult learners, because we cannot always expect someone invite us and then make us to sit in a place and then learn. And the same thing happens in the classroom also. As we expect us to be trained by others in a formal setting, we also expect our student, make our student to sit in a classroom and make them to learn. We are only producing learners. Gone are those days we believed in learning. Now we are in the age of critical thinking. We need to make our learners to think. If we try to develop thinkers, automatically learning will happen. So our faculty development first basically should focus on training the teachers on how to make their learners think. So that is the need of the hour in competency-based, because competency-based medical education focuses on developing competencies which the learner should be able to demonstrate in appropriate environment, that is in real life setting. To happen, you cannot spoon feed or you cannot formally train our learners in all this thing. Of course, the NMC has identified certain certifiable skills which we are training, but we cannot train everything. For that, you need to create a thirst among the learners. To create that thirst, definitely you should make them to think. So the need of the hour is that we need to make our learners to think. We need to promote thinking. So the earlier traditional curriculum, I think people would remember the objectives of the 1997 curriculum, which says the objective of the Indian medical graduate is to serve as a clinician. That means preventive, promotive, curative, and rehabilitative aspect of the health. So that was the only purpose. But now, along with this role of a clinician, we have added 6 more elements. That is the role of a communicator, collaborator, researcher, critical thinker, and professional. All these things need to be. If you think that if you want to develop all these abilities in our students, the teachers need to be first of all skilled enough. So the faculty development programs, apart from formal training, we also need informal, non-formal training like this platform, and informal training. That refers to availability of resources like pamphlets, articles, small information leaflets, all these things, so that whenever a faculty crosses the any educational environment or any learning event, they should come across such things so that they'll come to know, yes, what do you mean? What does it mean by authentic assessment? What does it mean by learner-centeredness? So that kind of informal training will also help the faculty members. So now coming to the aspects of the formal thing, now there are, strategies. So what I mentioned was about the, is about the formal training, informal and non-formal. The other aspect is there are now lot of platforms available for the teachers. It's not one or two. So now gone are those days where people were depending on others' resources. Now we are in the world of creation, and every teacher can create their own resource for their own self-development. So how many teachers, usually I talk this in our faculty development programs, I used to ask this question: if you really believe in self-development, please don't expect someone to come and develop your abilities. So first start documenting whatever you do in your day-to-day classroom. So you ask for yourself. I would like to ask all the panel, the members of this group, the audience of this group, how many of us are maintaining a teaching portfolio? Before thinking of faculty development, so are we maintaining a teaching learning portfolio? So what is this teaching portfolio? So it is evidence, or it is a documentation of the day-to-day activities a teacher, starting from a lesson plan, identifying the content, identifying the the appropriate pedagogy, identifying the method of assessment or whatever it is, the feedback from the administrators. So if you could maintain a teaching portfolio, definitely that will help everyone, each one of us, to identify the area where we lack, and we can appropriately select such a faculty developer. So these are all some of the strategies. So if you want to identify appropriate strategies, it will not be like one size fits all. So different faculty needs different requirements, and the first duty of the apex body is to identify the requirements, the needs assessment of the teachers. Basically, teachers need to be trained in the concept of CBME and how to implement CBME and evaluate the CBME, for which the faculty need to be trained through different means by using formal, informal, and non-formal training, using online platforms, using peer learning. So there are a lot of small things called as the learning circles, where a group of learning faculty interested in particular this thing, say community of practice, you learn. So post a small topic in that and we can learn. So now in those days, institute was the only resource. Books were the only resource. Now there are a lot of avenues available for faculty development. It all depends on how creative the administrators are. So how determined the administrators are. So based on that, they can choose to go for any type of faculty development strategy. So still there are a lot of other things. In the interest of time, I'm just restricting my this thing.
Thank you so much, sir. You have covered so many aspects of training of faculty. Even in 1997, we find many of the elements of CBME existed in the 1997 Graduate Medical Education Regulations, which were amended up to 2018. But why did it work then? Because there was no training of faculty. I honestly believe that. And even 2012, there was a document with the same elements. It didn't work. Vision 2025 did not work. I feel there was inadequate training of formal training of faculty. It has worked now, and it has worked how well, because of the training that all the regional and nodal centers have taken up. It was very important because during post-graduation, none of us are taught teaching, technology. Maybe a B.Ed, a school teacher is taught, but dossier, doctor, is derived from the word docere, which means to teach. But unfortunately, teachers were never trained how to teach. So it was very important for basic course workshop to even learn what is teaching, learning, assessment methods. It was very important, sir. The revised basic course workshop has taught us competencies. But as you have rightly pointed out, what we need now are focused workshops. You did mention about informal training. It's so true. Passionate educationists will learn, and also informal ones reach out to a larger audience. Regional and nodal centers have very restrictive participants. You have regulations and who can attend these programs, like MEU members or curriculum committee members. But there are other faculty who are more interested, but because of their positions, designations, they are not up for promotions. All these regulations are preventing them. So these informal sessions are really working out, sir. And one more thing you mentioned about using the age-old PowerPoint presentations. So what we have done in our institution is lecture audit. So we have a group of medical education unit members. We have formed what's called as an academic monitoring committee, and they do lecture audit. We have taken all the elements of CBME, and we actually ask every month for all phases of MBBS, all disciplines, to post their PowerPoint presentations to MEU. And the members of the academic monitoring committee actually check all these and point out where they have missed out a few things, maybe even objectives they do not write, or interactive sessions, competencies are not mentioned, outcomes are not mentioned, review questions are not part of the PowerPoint. So we are doing this lecture audit as well. That was a very important point you brought out, sir. And you mentioned about some kind of mapping that we need to do. You mentioned there are a number of program outcomes. So what we are not doing through a NMC is laying down the program outcomes and course outcomes. NMC mentions objectives, but NMC does not give the word outcome. So it's very difficult for faculty to align themselves to the word outcome. If you see the dictionary meaning, the outcome and objectives appear almost the same. And faculty look at it from their point of view and not from the student's point of view. So what we need to do is we need to frame course outcomes, program outcomes, and map course and program outcomes. That is one more exercise probably we need to do formally as well, so that there is uniformity in the country. So thank you so much, sir, for giving very good insights about the gaps that we are seeing in the training of faculty. So we are done with the first round of questions. I hope we have adequate time for the second round of questions. So ma'am, Sunita ma'am, can you take this question, please? Could you provide some examples of best practices or innovative tools that you consider are effective models for implementing CBME assessments?
Thank you very much, ma'am. Again, one of the very thought of questions, because we are talking of a lot of theoretical things. There are so many tools, there are so many methods which are not practical or feasible. We talk of theory, but for implementation, when it comes to, we really have challenges. In that, what in these best practices which are feasible that we can do easily is, first thing is a blueprinting. Blueprinting for assessment for both theory as well as practical assessment in one blueprint, so that there is no overlap and we are using all the tools and methods judiciously and appropriately. That is first thing. Blueprint is the first thing. Second thing, I would like to share our experience of what we are doing is in our institute, integrated assessment along with alignment. Actually, we are implementing that. Like now we have a timetable for theory in all the classes. So that is aligned with all the 3 subjects. Like in our, we are doing it for first years and all, but I am sharing our experience of second years. Pathology, microbiology, pharmacology, and wherever required, community medicine. We have an integrated assessment at the end of that block, at that end of week, of that aligned week. For example, anemia or diabetes or cardiovascular hypertension, something like this we have. So at the end of the week, when we are having integrated assessment, what we do is, we all departments come together Usually it is a pathology who takes the initiative of constructing the case. We construct a case and we add multiple choice questions, true or false questions, or one or short answer questions, and we share it with others. So it gets circulated. We plan it at least 2 weeks ahead of the integrated assessment. Then the same scenario with our questions go into for microbiology. Microbiology will add their questions to that. Pharmacology will add their questions to that. Community medicine, if applicable, will add their questions, and we shuffle all the questions. So it is actually integrated. So students are not answering pathology questions, microbiology questions. There is a case scenario in that, there is a context, in that context, students are answering. And we have an assessment that is working well for us, but actually how much we have achieved, we really don't know. But this is what working, and on the feedback, students are appreciating it. That is one which is a good practice that we can do, which is doable. The third thing is certifiable skills. Especially, we have to have a separate timetable for certifiable skills. What is happening in a real gap, what we can see is, ma'am, we have skills, they are they are kept in the timetable, no doubt. But what happens is there is a prior preparation is not there. Most of our faculty, what I have seen is in clinical side, especially, I mean, with due respect to all clinicians, that not that way. They start running around when tomorrow's there is an assessment, tomorrow it is going to be done. And then they start planning, I mean, what to do. Or today morning, now, oh, we have to assess also. So there is somewhere that assessment is not happening. If we have a certifiable, ideally, we should have for all the assessments like SGT, ATCOM, everything, we have to have a separate list of or a timetable. But practically, if not for all, practically, at least for certifiable skills that are important. And we have to have a blueprint for that also, for a cumulative. For example, if I am assessing, again, I'll take an example of an IV cannula. There is a knowledge, some knowledge component, because what he should know, the indications student should know. Then we have some skill aspect. Then we also have an affective domain aspect. We are assessing communication, convincing the patient, or taking consent, taking history we are taking. But these generally what is happening is at COM we are assessing separately. In groups, we are SGDs, we are assessing theoretical separately, SDL, we are assessing separately, and skills, we are assessing separately. If we can have all of these in cumulative, though we are assessing separately, we enter this into that particular domain, if one cumulative grade for a particular assessment, then in the end, we get an overall view of how the student is performing in what way. If we can have that, that will be the ideal. Of course, it takes a little more efforts. The fourth one is a real-time entry into logbook with feedback. The major gap, according to me, is logbook entry. What I have seen, including my own department, including myself, the logbook entry has not been taken properly. In a sense, when I am there, I am assessing my, small group that has been assigned to me. I am assessing, the student has not got a logbook. And there is no entry. When the student comes with a logbook, I am not available, because we are also multitasking sometimes with the assessment. So that remains. And in the end, it becomes, most of us, it becomes a formality just to enter something over there. So it just becomes a formality. We assign something and it go. So that is not happening, and feedback is not happening. If we have to look at actually the logbook, looking at the outcomes, what that we want, the cumulative assessments with logbook, a real-time authentic entry with feedback helps us a lot. I also conducted a study as a part of my, I have just completed my psychology. So my master's in psychology. As a part of that, I just took an project, and I was also curious to know what are the factors actually that help students learn. It was a part of educational psychology. And what are the factors that hinders their learning? When I ask some open-ended questions, I can share that sheet with you. Majority of the students said remove SDL, because the teachers are giving it to us. They're giving it to us, and we are not learning anything. It's only active, or maybe they are not interested. I don't know how it is implemented. Second thing is there's a remove logbook, because logbook in the end term, they run around. They said before examination, it is a time consuming. We just have to theoretically run around to reach to the professors and get this logbook signature. Then where is an implementation of what we are talking? If it is logbook is not entered at the end of the term, if they're running around, that means logbook entry is not happening. I'm talking of my own institutes. And we are a nodal center. I mean, I can tell you nodal center. I just read it in one of the comments. Somebody said in private colleges, medical education is given a stepmotherly treatment. In our observation as nodal center and regional center, as we go for observers to other colleges, no offense meant to anybody here with any college. I can say that in private institutions and deemed universities, medical education gets a stepmotherly treatment. I totally agree. But in government colleges, it is an orphan completely. Nobody takes care of it. People don't know about timetable. People don't know about alignment. What is alignment? We are doing the older methods. We are going to do the same thing. So if this is happening, then we will not be able to achieve. The last but not the least, of course, in this, what I want to highlight is we have to understand the needs of Gen Z. Because we are talking of our own methods. We are talking the students are not attending. Yes, students lack of interest, the lack of attention span, lack of things. We have n number of the huge list of complaints among the students. That is because we are not catering to their needs. Gen Z is different. They're technologically ahead. We are still sitting with an age-old one. We are still sitting that, we are stuck with our own education system. When we studied, we all keep saying, I'm sure we all have heard it, Are humne kiya na, we have done it na. Why can't they do it? Today's generation, today's students are not interested. Today's students are, they're least interested. I mean, we put the blame. It's not so. If we talk to them, that study told me, when I conducted a study, I'm publishing it, I will share it. It told me that, madam, we don't want to sit in the class that is going through the just PPTs. Like somebody mentions, all this turning these programs are becoming what you say, this BCME, whatever, is just a PPT turning out to be certification because NMC has made it mandatory and linked to the promotions. They have just become just a formality, certifying. Out of that, in our observation, barely about 20 to 30% of the people go back and implement, and they are genuinely interested. So the faculty development is required. However, that is not a complete answer. Second, I also would like to add here that one of the panelists mentioned that mindset has to change. So people, and still, even the first batch is coming out, still people are in denial that there is CBME. Still they're in the criticizing and
sweet
yeah.
Ma'am,
Ma'am, can you please mute yourself? Babita, madam? Yeah. So we are
yes, ma'am, sorry.
We are still not accepting it. Accept it and change the mindset and understand the needs of the learners. We go a long way. This is what I had to say. Thank you so much for asking me this question, ma'am. Something close to my heart.
Thank you for bringing up Gen Z, ma'am. I think Dr. Jayaparasarasan sir had also mentioned it. We should change the way our classrooms are, first of all. The setup itself, the lecture hall, maybe we should not have that gallery type lecture hall where the teacher still is a sage on the stage and not a friend by the side. Definitely not friend by the side. So we need to change the location, the infrastructure. We should start with that and probably have more of these flipped classroom kind of sessions rather than didactic lectures. So that is one way where we can get all 100 students involved. Maybe those Socrates clickers where you ask them questions and they click and you get to see their responses, where all 150 or 200 students are involved. Probably, yes. Jayaparasarasan sir, Sudha ma'am, and yourself, ma'am, Sunita ma'am, and John Stephen sir, you are all conveners of medical education technology. Please have focused workshops on teaching methods. Jayaparasarasan sir did mention about informal ways of learning, online learning. Of course, Coursera has lots of these kind of how you change the classroom. There's one called Teaching Character and Creating Positive Classrooms. And it has a lot of these technologies where student engagement is much more than the contribution by the teacher. But in spite of that, as we have all seen, if the NMC were not to monitor us, monitor the institutions, I'm sure we would not stand up to the standard of NMC either. We all need monitoring. whether it is students or faculty. So informal ways, I doubt we are adult learners who are rogues. We may not learn. So if it is thrust upon us by NMC, that is one of the prerequisites to be a medical teacher, probably that would work. So all of you being conveners, please have a thought over it and bring about focused workshops on teaching, learning methodology and assessment methods for Gen Z. That would really help us, because we are at a loss on how to handle children who are born with gadgets. And we were not born with gadgets, and we try to take that appendage away from them, and they do not understand us. So how to use those gadgets is what we need to learn. Thank you so much, ma'am. And one more thing I really liked was your integrated assessment. We were halfway there. We were not a full fledged CBME curriculum, because assessment has to align with teaching learning methodology. So we have alignment and integration without having integrated assessment. But of course, NMC has corrected itself. In the CBME guidelines 2024, we have 6 integrated modules that NMC has mentioned, and assessment from phase 1 to final phase would have integrated questions. There are 4 questions of probably 5 marks each on integrated module. Those integrated module are the diseases which are seen commonly in India, like tuberculosis, hypertension, diabetes, thyroid disorders, PCOS, and anemia. These are the 6 modules. And from phase 1 to final phase, we are supposed to have these short answer questions of probably 5 marks each in the assessment. But thank you, ma'am. You are already at it. I guess there are formative assessments where you have integrated assessment. Since you are a deemed university, if you can have it for summative assessment also, it would motivate the other universities to go ahead with the same. Thank you, ma'am. Next, Sudha, ma'am, if you are up to it, can I ask you one question? It is about standardization of practical examination. Now we have the 2024 document has given a blueprint for the theory examination. So there would be uniformity in the blueprinting of theory paper. So there was a question from one of the office bearers of IAME on should there not be a standardized practical examination framework across the country, regardless of the university, in terms of marking, exercises, and time allocated for each topic. What is your view about it, ma'am?
Yeah, thank you for that question. I absolutely agree. But first of all, there should be standardization of teaching. So only then we can assess the assessment standardization can be done. So one example recently, which when I went through this UG practical exam, there is a OSCE, both for UGs and PGs. So even when we were going through that exercise in our own department, I found like a lot of lacunae in the development of OSCEs as such and how it can be, made better. It's just an example only. But what we did, like we also, wherever the faculty go as examiners, they also tend to get all these exercises and OSCE and things like that. Even in that one particular aspect, I saw a lot of discrepancies. Like, it needed a lot of working and improvisation and all that. So at that time, I was thinking what the students are being assessed in a different university in Karnataka or Kerala and what we are doing. It's totally different. Like though we call it OSCE, the questions are different. Checklist is different. And we have not designed it based on the curriculum document. So everything is in different direction. So how to harmonize it is a big challenge with a country that is such a big country with a lot of medical colleges, and every day new colleges are coming up. As you rightly put it, like the Gen Z and the teachers who are the millennials who keep moving. They're not like us who are in one place. So I find the younger faculty moving towards better frontiers, as I said before. So a lot of challenges are there, but nevertheless, as you had suggested, we can have a consortium kind of approach, or the regional centers and the nodal centers can make a lot of efforts to harmonize these assessment methods so that all students are taught in a similar way and all students are assessed in a standardized way. So I think a lot of work needs to be done, a lot of work ahead. And yeah, I don't know what else to say because the challenges are common and, solutions are few.
Absolutely, ma'am. Even the next exam, the theory was standardized. It was a common exam for the entire country. But when it came to practicals, they wanted each university. The NMC would recognize a particular university and they were supposed to conduct. And based on the feasibility, the infrastructure at that particular medical college or university, the examination, practical exam pattern would have been different. Yes, it is very challenging, but I'm sure you erudite panelists who are conveners, I'm sure you will come up with a solution. We'll await that, ma'am.
One point I wanted to add as an example. So for PG exams, it's not about UG, but for PG exams, now totally for community medicine, for us in Tamil Nadu, they've taken off pedagogy. There is no pedagogy. Whereas, they put it as with the family case, which I think is a big, we need pedagogy separately because the bread and butter of community medicine is to teach, right? Common career option. So such things need to be streamlined and looked at.
That's true, ma'am. Dr. Vijay Karthikeyan, I think we have added pedagogy in Viva for the 2022 batch onwards. Yes, there is no pedagogy. Up to 2021, it was a different curriculum. 22 onwards, the PGs have a different curriculum, revised curriculum in basic sciences, community medicine, and some clinical sciences like ortho and pediatrics medicine and so on. So in 2022 curriculum, there's no pedagogy. But we are a deemed university with 3 constituent medical colleges. So as you rightly pointed out, ma'am, the heads of departments of community medicine did mention that pedagogy is a very important part of community medicine. And we decided to add it as part of Viva and not in the practical exam per se. Thank you for taking that question, ma'am. The next question, can I ask Dr. Vijay Karthikeyan, do we have the time to continue with our questions or should we take audience questions if any questions are there in the audience?
Ma'am, we can go quickly for 2 minutes or 1 or 2 minutes.
Okay, fine. So I request the panelists, we'll discuss very quickly. Zayaparasarasan sir, what role does technology play? I think it has already been answered by you in bridging assessment gaps in CBME and how can it be utilized to achieve better outcomes? Technology. So you're muted.
Yeah, I'll make it very brief, ma'am. So since I already touched upon the technology component, I'll make it very short. So technology has a very larger role to play in medical education. In those days, teachers were fully depending on the one set of one exam, and the students will be looking forward for only that exam. And the only data that we have about the student is the final marks. So which that itself we call it as a big data. But nowadays, except for that final marks, we have lot of data available about our learner. In those days, it was very difficult to understand who our learners are. Now it is very easy to understand who our learners are. So with the help of technology, all these are possible. So a teacher need to be more well equipped with as good as he may be very good at content. So he should be well versed in making the content, identifying appropriate pedagogy for the content as well as appropriate technology. So there is a model called as TPAC, techno-pedagogical content knowledge, which helps a teacher to appropriately blend all these 3 things so that you can easily reach these students effectively. So technology has a larger role to play. Now teachers, I think I don't have to say, no, even the same PowerPoint, now it can be made interactive. There are a lot of softwares available to make your PowerPoint interactive, where you can add polls, where you can add short questions like that. And then now with the help of different assessment tools like Kahoot and other things, so formative assessment can be done. So assess while you teach is very possible. In those days, only magic wand the teacher uses is the questioning tool. So with the help of the questioning tool, the teacher uses that is the only interactive tool a teacher uses in the classroom in those days. Now you have a lot of interactive elements like audience response systems like that. So a teacher need to equip themselves. As they equip themselves with the content, they also have to build, equip themselves with their pedagogy and along with the technology. Now we are in the age of artificial intelligence. Now in those days, just some 2 years back, there was a site called a Sessions Lab. If you post the content, what you are going to teach, it will create a session plan for you. Now the job is whatever job, there is a site for test maker, you post the content, it will create MCQs. But now all these jobs can be integratedly done by holistically done by the artificial intelligence, chat GPT or DeepSeek. So post the content and whatever question prompt you post, it will give you MCQs or a session plan or a case scenario. So like that. So I have forgotten to mention about the faculty development strategies. So now those, some few years back, teachers would be struggling to do micro teaching or scenario-based teaching. Now there are a lot of techniques available to train the teachers using micro scenario-based teaching, or you say there is another option called as objectively structured teaching exercise like micro teaching. So all these things can be done using can be done virtually. So a teacher in California can give me feedback after watching my this thing. All this is possible, and you can develop effective, more educationally sound MCQs, session plans, case scenarios using artificial intelligence. So other things, I think most of our technology, our people, the audience may be aware. One important thing why we need to use technology at this point of time is that to understand our learners, technology is the only way. So there are a lot of hidden data about our learners available, which we are totally ignoring. Except for the summative or the formative assessment marks, we have no other data about our learners. If we start using technology, definitely we can track our learners. Who are our learners? What are their interests? What is their learning style? What is the notional learning time used by them? So we can appropriately design personalized content for our learners with the help of adaptive technology. So adaptive technology helps the teachers to track their learners, and with the help of artificial intelligence, adaptive technology helps the teachers to design unique content for their learners, unique assessment. So that is the need of that. That will definitely help to achieve the competency-based medical education. So still there are a lot of other things. In the interest of time, I'm just want to help the moderator to finish on time. So if someone is interested, definitely people can write to us, to all the moderators, so that definitely we are here to help the people who are interested in technology.
Thank you so much for sharing that insight, and also wanting to help our audience after the panel discussion is done with. You have hit the nail on, sir. Tracking the progress of students has been simplified by the use of technology and providing personalized education to the students. I think that's what is the need of the hour. Thank you so much, sir, for that. John Stephen, sir, just a question for you. In what ways can insights gained from international medical education systems be utilized to enhance CBME practices in India? So you're muted.
No, just want to mention 2 points after listening to that 1 hour session. The first point is that I think one analogy that I want to give here is this, that we all do group work, right? We love group work in our trainings, and we think that's a fantastic method of teaching. And when we tell the group to say, let's say, discuss and present a role play, most of the learning is done when they're designing the role play. The final thing that happens is the role play on the stage, but they've already done the learning by that time. In some ways, I think this analogy why I mentioned is that the summative assessment is it's not going to be possible to assess everything, right? The most important part is what happens in the 5 years. And we need to sort of look at how we can change systems so that it actually is CBME. by just tweaking. Yes, you need to standardize. Yes, you need to have a summative exam and the quality has to be good. But the more important part is what happens in the 5 years. By the time they are ready to take the final exam, most of the learning or whatever has happened already. So that's for the first point. So in that sense, if you look at it, the key, of course, to CBME is formative assessment. I mean, without formative assessment, there is no CBME. And the key to formative assessment is feedback. And without feedback, there is no formative assessment, therefore no CBME. So the challenge for us is always the feedback. Because, I mean, giving feedback to a whole class and saying, you give an MCQ, that's the easiest, the low-hanging fruit. You give a knowledge-based questionnaire and give them the marks, that's the lowest feedback you can give. But the challenge is in giving them the feedback on a 1:1 basis when they come to the clinics, for example, or even in other subjects. Now, that is the challenge. And the numbers game is a big thing now. Now they are going to grant some more seats, and I don't know whether they're going to increase the number of faculty. Now, if you're going from 150 to 250, how is that going to be? So the other point that I want to bring was we've been talking about these tools, so many tools, from work-based place-based assessments to OSCEs, to you can go on about tools and tools and tools. And but all those things are good, and some of us actually use it, but it makes a difference to the student when it becomes part of institution culture. And I think for CBME, we had to change what most of the panelists have said, what we were used to before, to a new culture now. And that's not going to happen overnight. And in some ways, NMC started very well. That time, MCI. And what was the first thing that to do? They did basic course, and they just brought in a lot of people to become familiar with just the terminologies of medical education. They brought the advanced course. They brought the CISP. And when we started to, and if you look at the CBME, they brought in few important system change in education. For example, foundation course, early clinical exposure, student doctor method, I mean, integrated learning. All these are systems that they brought in. And I remember when we were part of the monitoring group, we in the discussion, we said, the first part is, let's make sure that they've already started. That's enough. You know, the first year, the monitoring was, have they started foundation course? Have they started early clinical exposure? Have they started? We will go into quality and other things a little later. It had to go step by step. It doesn't change overnight, right? So I think it's not going to happen that way. So we'll have to start setting up systems. Now, what happens in most of our institutions is we all go for a workshop. We are excited about workplace-based assessment. 2 people do it in the department. Another department does it. It's a fantastic thing. You get a paper out of it, but it has not been part of institutional culture. So the students experience it in one area, but not in all areas. So, for example, in our institution, peer evaluation is part of an every year activity. We started an audit of CBME. Each department will evaluate what the other person has done with the checklist and other things. So audit is part of a regular activity. We have a question bank, which is, case-based, like Dr. Zayaparasarasan was saying, focus on case-based clinical reasoning, and, the questions that you're going to get for interns only that. So I think one of the things that perhaps we'll have to go towards is NMC is not doing that. They're not monitoring quality, okay? Now, if, for example, even quality in terms of number of beds, number of patients, some colleges don't have patients, what CBME you're talking about? Okay, they have a skills lab. I've gone to many skills lab. Not many people are actually using this. Now, it has happened. Many institutions have started to do that. Yes, we have to give it time. But I think ensuring quality now, and the way the central NMC has to monitor and say, there is quality in the institution, because by the time they come to the 5th year, what you have taught and not taught is already done. I mean, you can talk about how to use a PowerPoint, but once you have a system in place, a new faculty coming from another institution, doesn't matter. There's a system in place. They will do that. And when we joined a medical college as teachers, we followed the system that was existing. We were taught in a system. We went ahead and took the lectures. We knew a little bit of what tutorials was. So I think, for example, we had one lecture from one of our colleagues from Canada, Dr. Vincent Zayaparasarasan. And he was talking about workplace-based assessment for undergraduate students and how they have established that. And that's the system all over. And it's a well-oiled system. If that sort of a thing happens, then it will definitely affect the quality. But we do talk about so many of these. For example, LMS is a recommendation by NMC, a learning management system that all institutions should have. But we've not moved there. But I guess we got to give it time. But till we do that and, do it in large scale, it's not, if it's going to be, a one-off institute that's doing it or one-off departments that are doing it, that's not going to touch it. So as medical education unit, I think our job is to sort of facilitate that or give leadership to not just trying it out in a department, but to see how you can set it up as an ongoing process. Okay, only then slowly the new generation of faculty will get used to that particular pattern and that change will occur. It will not occur in the next 3 years. It will take some time.
Thank you for your insight on formative assessments. I think all of you have stressed and emphasized on formative assessment from the start, and the learning management system. I think it will help us to give personalized education, as Dr. Zayaparasarasan sir was suggesting. Thank you, sir, for your insight. I think we are coming to an end of the panel discussion. Is there time to take any of the audience questions? Dr. Vijay, Dr. Kribakaran?
Yes, ma'am. We can take 1 or 2 audience questions.
Okay. If anybody wants to unmute yourself and ask a question.
Good evening to all the panelists. I'm Dr. Venkatesh from Department of Community Medicine in the BGS Medical College. With regard to the assessment, the challenge is always there. In terms of putting across assessment with regard to small group teaching as well as the other things like ADCOM, to make it real time and to make everything do that when everybody, faculty do that when, what are the different methods being used is all my questions all about. That's one thing. And with regard to, this is not a question. The second one is actually how we could do it, because a lot of questions were asked, can we really do it? Recently about a sociology class that I took, I prepared an MCQ at the end of the session with a scenario based for the students to be administered, and I gave the feedback after the scoring and concurrently.
Any of the panelists would like to take sir's question on ADCOM?
One thing is in ADCOM, one of the things, because like Sir mentioned, the challenge is the numbers itself. How can we give individual feedback? One thing is we can use technology, of course, and we can use cases and videos and things like that, where they can write reflections, and the reflections, it can be at your own time you can give them feedback individually. Okay, so that can be done. If we have case scenarios on which you assign and ask the students to write a reflection, and that's where the LMS will come in. There could be a discussion board and you can chip in and give your feedback. So that can be, it doesn't have to be synchronous, it could be asynchronous. So that gives you the flexibility, because the numbers, student versus faculty, is going to be that challenge. So this asynchronous method will give you that flexibility.
Thank you, sir. One more question. Anyone else would like to ask? One thing I want to mention is that Dr. Vijay has saved the transcripts, so we can go through all the comments which have been passed on to all the panelists. We can share it with the panelists. There might be a lot of questions as well, which I hope the panelists don't mind in answering. And I hope all of you are members of IAME, so that we can post those responses of the panelists on the group. Anybody else would like to ask? Yes.
Thank you, Deepti ma'am. I have a question. Like we had been talking about LMS, but majority of the colleges, they don't have, like I was asking, and LMS is the need of the hour. So what could we do to incorporate this LMS, and what is the process? I belong to Government Medical College in West Bengal. I'm Professor Dr. Tanushri. Thank you.
Well, can I answer that, Doctor?
Sir, please do answer, sir. Sanjay Bedi, sir.
Yes. We have been running these courses on Moodle since very long time. And I mean, so basically what is needed is the will of the college that it is not very expensive. It is basically you have to take training and you have to employ at least 1 or 2 IT people who are trained in IT, who can handle that, who can be trained in that Moodle. Other learning management systems are also available. If nothing else, a simple Google Classroom is there, but that is a lot of you use that during the COVID, but how to I mean, it's basically a will to change. And now we are coming up with another tool, which is a learning management system with some built-in questionnaires with that will be announced in a few days. But these things are available. But what is needed is basically a will on the part of the management, or at least the head of department.
Thank you for your
Dr.
response, sir.
Deepti, yes.
Yes, sir. Thank you, sir. And of course, you introduced us to Google Classroom during COVID time. How can we forget that? And the audience has also, participants have mentioned it. You were very much involved in e-learning technologies for faculty. So thank you,
Yes.
sir. You are our Vishwa Guru, I must say, in teaching us how to use technology to learn. Thank you, sir. I think Dr. John Stephen, sir, you want to add?
No, like Dr. Sanjay Bedi said, I think it has to start with the administration, the institution, to take that call and say we want that, because that's when it happens. There are a lot of platforms. For the person who asked the question, Moodle is one of them. For example, St. John's, initially we used to use the Tufts platform. We called it the, from Tufts University, okay, and the Tusk platform. And we have something called Open EDX, and that's what they're using in St. John's now. But you have to customize to your own needs. And as Dr. Zayaparasarasan said, that data analytics, and you want, now there's so much more that's coming in. So all that needs to be incorporated. That's one part of the story. But how to get faculty involved into this platform is another thing that somebody has to strategize. Okay, the IT person will build the back end, but the medical education unit has to take all the faculty on, because that stickiness to the platform has to be there. They have to start using the platform. They have to be looking at it. They have to come in the morning and sign in every day. That will take time. You have to take them through steps and go from, steps, and it's a process. But I think for what all the things that we want to use the AI and other digital advantages, LMS is something as a basic thing on which the platform on which we can plug all these things. We'll need that in the future for sure. We better get used to that, because as time goes by, and we are looking at one of the things, and how familiar are students with technology, and we want to compare it with how familiar are teachers with technology. What is the distance between what the students are familiar with and what the teachers are using? And we'll see what that thing comes in, because students perhaps are using far more material. We think of only ChatGPT. There are so many more that our students are already using. And can we allow ChatGPT in the exam? Can we have an open book exam? We are trying it out and saying at the end of the day, future is going to be where, like what we do in clinics, we check immediately. We want to clarify our doubts. We want from dosages to new diseases to whatever. Now, will we come to a stage where we'll have an open book exam where it's reasoning that we're looking at? I mean, so anyway, for all this, LMS is the platform on which we can plug all these things. So we better get onto it and get familiar with that, before it's too late. Yeah.
I have a question.
Thank you,
Can
sir.
I?
Yes, sir. So one last question because we have crossed the time.
Yeah, I mean, just a brief question. I mean, I just wanted to know from the expert panel here, should the medical education policies, should they focus more on equalizing opportunities or equalizing outcomes?
Any
And
panelists want to
it
say?
looks like the CBME is and then it's trusting all the medical colleges towards equalizing the outcomes, not really focusing only on providing equal opportunities. So that is the problem that most of the medical colleges are now facing, wherein in order to ensure that they have provided equal opportunities, they're indirectly equalizing the outcomes, which is promoting a lot of mediocrity and psychophancy.
Any of the panelists wants to take the
No,
question?
I don't know. In terms of medical colleges and the infrastructure, the quality of faculty, the number of patients, it's going to vary. It's going to be heterogeneous, right? And we know there are students from inverted commas, good colleges, mediocre colleges, and bad colleges. So the quality depends on that. In some ways, whatever the NMC is doing is, looking at inspections to see basic minimum standards, I think is in that say that at least this much should be because at the end of the day, the process is important, right? I mean, the hidden curriculum, we haven't talked about at all. We are talking about what we are defining here. A lot of the learning occurs in the hidden curriculum, right? And that can be defined only by the process and the quality of the environment in which they're there. And if NMC has to ensure that that minimum quality, minimum environment has to be there, because a major part of what a good doctor is comes from the hidden curriculum.
Thank you, sir. I think we have come to the limit of our time. We will respond to all the questions which are posted by the audience, and we really appreciate there are more than 100 to 200 responses or discussion topics posted by the participants. We'll respond to each one of them. Yes, ma'am. Sunita.
Last one, just one summing up statement I would like to. This I'm just sharing from Dr. Tejinder Singh's talk in NCHP 24. He was talking from CBME from the previous to now the journey of CBME. In the last slide mentioned, he had mentioned that मंजिल तो मिल ही जाएगी भटकते ही सही शिकवा तो वो करे जो घर से निकले ही नहीं, which really touched me. So in a sense that, see, we have a lot of challenges in CBME, no doubt, a lot of challenges, but at least if we can put some efforts somewhere at least we'll be able to reach. So that was my concluding thing. Thank you so much for this opportunity.
And thank you so much for that punchline that you have given as a concluding remark, ma'am. And thank you, Sanjay Bedi, sir, for that inspiring words. So as we come to an end to today's discussion, I would like to express my sincere gratitude to all of you panelists for your elaborate explanations and insights, which we can't seem to have enough. I'm sure the audience can't have enough either. Thank you all for joining us today. I would also like to thank all the audience members for their engaging discussions that they have posted on chat, and also thought-provoking questions, which I noticed, but because of paucity of time, not able to take it up. I wish that everyone has great success in implementing the best practices that have been shared by the panelists today in today's discussion. Dr. Krubakaran, do we have time for you to summarize, or shall we put the summary in the WhatsApp group? Dr. Vijay,
Yeah, we
what do you
can
say?
Yes,
We'll
we
do that,
can
right?
put it in the WhatsApp group. Yeah.
Kripa sir,
Okay, thank you.
any points, any thoughts from your side, sir?
Yes, yes, sir. So it was a fantastic demonstration, online panel discussion in short time, right from the choice of speakers to like a seamless flow of sessions. So all the panelists are very stalwart in their own background, and I want to thank everyone, especially Dr. Sudha ma'am. We were not sure that ma'am's availability till today's afternoon, and special mention to Deepti ma'am to navigating these uh, online sessions very actively and knowledgeably. And
Thank you.
and I want one point I want to mention is out of all the participants in this online uh, panel discussion, if you want to come up with any other ideas and suggestions in future academic programs regarding IAM, you can contact us so that we can plan every week or once in a month, something like that. You can come up with your suggestions to us. So over to you, Vijay Karthikeyan.
Thank you, sir. Dr. Kribakaran sir is our founder of IAME and is also the National General Secretary of IAME. Thank you, sir. Thank you for your thoughts. Next, I would like to invite Professor Dr. Sheila Sivam ma'am, who is the Vice Principal of MES Medical College and is also the Deputy Secretary of IAME to deliver the vote of thanks.
Good evening, one and all. That was a excellent brainstorming session with our expert panelists here. And I would like to thank IAME for organizing such a wonderful session, which is beneficial for all the faculties all over India. And let me take this opportunity to express my heartfelt gratitude to our esteemed panelists, Dr. John sir, Sunita madam, Sudha ma'am, and Zayaparasarasan sir. And I also take this opportunity to immensely thank our beloved Deepti madam for very efficiently and effectively moderating the session. And any program is not complete with the participants, and we have seen the very active participation of a very large number of participants here in this brainstorming session today. Even though we couldn't answer all the questions, anyway, we'll be getting back to you soon. And once again, on behalf of me as well as IAME, I thank each and every one of you for participating and making this online program a great success. Thank you.
Thank you.
Thank you, ma'am.
Thank you all. Thank you very much.
Thank you.
Thank you. Once again, on
Thank
behalf
you,
of
Dr.
the
Deepti.
Thank you, sir. Thank you, sir.
thank you.
And
Once
ma'am,
again,
your
on
moderation was really amazing, Dr. Deepti ma'am.
Yes.
Thank you, sir.
Really
I
amazing.
wanted to say.
I've learned
Very nice.
from the best teachers like you.
No, really, very nice. So I
Yeah,
thank all my faculty, panelists and all the audience for their active participation. All the best. Thank you, ma'am.
Thank you. Thank you all. Thank you.
Yeah, thank you so much.
Thank you, everyone.
Thank you.
Once again, on the behalf of the organizing committee, I would like to extend my heartfelt gratitude to all the panelists, moderator, the office bearers of IAME, and all the participants for your valuable time and contributing in this enriching learning experience. We will soon meet in some other engaging event from IAME. Thank you all for joining today.
Thank you.
Thank you.
Thank you. Thank you, ma'am. Thank you,
Thanks,
Deepti, ma'am.
Vijay.
Thank you, John, sir.
Thank you.
Thank you, Sunita, ma'am. Thank you, Sudha, ma'am. Thank you, Zayaparasarasan, sir. Thank you. Thank you.
Yes.
Sir, we have provided our numbers. Can we please be added in the IAME group?
Actually, ma'am, the current WhatsApp group is full, ma'am. We have a Telegram group. I will just share that Telegram group link to the number which is shared in the chat.
We can add 1 or 2 contacts, sir. I think we can add 1 or 2 contacts.
Sure,
now.
sir. Sure, sir.
Thank you so much.
Thank you.
Thank you. Good night.
President,
Good
sir.
night,
Thank
everyone.
you.
Good night, everyone.
Thank you.